Picture this. You're stepping onto the pediatric floor for the very first time. Or maybe you're sitting down, taking a deep breath, and staring at your very first NCLEX question. The stakes are high, and honestly, the questions can be incredibly tricky. Well, welcome to this explainer. We are going to dive right into the ultimate pediatric nursing traps to make sure you absolutely dominate your clinicals and your boards. We're skipping the fluff today and focusing purely on the high-yield clinical priorities, safety alerts, and exactly what the nurse should do first.
Okay, let's jump straight into this with a classic high-stakes scenario right off the bat. Imagine you're assessing a 4-month-old infant and you palpate an open posterior fontanelle. I want you to pause for a second and really think, is an open posterior fontanelle at this specific age just a normal developmental finding? Or do we have a priority safety alert on our hands? What's going through your clinical mind right now?
Well, if you felt your internal nursing alarms blaring, you hit the nail on the head. The absolutely crucial point here is that posterior fontanelles should close by 2 months of age. That makes our 4-month-old a major red flag that requires immediate further assessment and provider notification. Now, on the flip side, the anterior fontanelles stay open much longer, typically closing anywhere from 12 to 24 months. A really quick memory trick for you. Posterior is passed quickly at 2 months, while anterior sticks around longer. Test writers love to mix these two up just to see if you're paying attention.
And you know, this closure timeline is a perfect example of why mastering pediatric differences isn't just about cramming facts to pass a test. It is literally about safe, priority-driven nursing care in the real world. Think about it. A missed fontanelle closure timeline could mean missing a critical neurological or developmental issue. When you truly understand the why behind the physical assessment, that's when you transition from being a student to a clinically safe practicing nurse.
All right, let's shift gears a bit and look at our next major priority. It is incredibly common to encounter a highly distressed, crying infant in practice. But the absolute gold standard solution here is a traumatized care. Instead of, pinning a terrified child flat on a cold exam table, we need to utilize comfort positioning techniques, like a side sit or a tummy-to-tummy sit with the caregiver. Keeping the parent involved doesn't just soothe the child, it actively prevents psychological trauma and builds trust, which is a massive priority on your exams.
Moving right along, let's talk about vital signs. Memorizing pediatric vitals can honestly feel like staring at the matrix. Let's simplify things and just chunk this data so you don't have to memorize a giant wall of numbers. What you really need to notice is the clear downward trend. A newborn's heart rate is super fast, anywhere from 110 to 160 beats per minute, with respiration zooming at 30 to 60. But as that child ages into adolescence, the heart rate drops to a baseline of 50 to 90 and respiration settle down to 16 to 19. The memory trick is simple. As age goes up, heart rate and respirations naturally trend down.
Now here is a massive test trap you've got to watch out for. Blood pressure cuff size. Matching the visual indicators on the cuff itself, like a small rabbit all the way up to an elephant, to the child's exact proportions is absolutely crucial. Because if you grab the wrong size cuff for a squirming toddler, your critical blood pressure readings are going to be completely skewed, and that leads to inappropriate clinical interventions. Always, always ensure the cuff size matches the child's arm correctly. Safety first, right? So we just said heart rate and respirations drop as a child ages, while blood pressure does the exact opposite. Notice this upward trend. A newborn's average blood pressure sits around a tiny 64/41. By the time they hit the infant stage, it climbs to 85/50, and it just steadily rises through school age until they hit that adolescent benchmark of under 120/80. The golden rule to remember here is inverse pattern recognition. As the kid gets older, the heart rate drops, but the blood pressure steadily rises.
And remember, pediatric growth isn't just about physical numbers on a vital sign machine. It's really a constant developmental battle between genetic nature and environmental nurture. Nature includes the hereditary traits locked in right at conception. Nurture is literally everything that happens after, including maternal health before birth. Things like poor intrauterine nutrition, maternal smoking, or environmental hazards have a profound impact on development. As a nurse, assessing a child means assessing their whole environment, not just their genetics.
Speaking of physical milestones, you will want to burn this timeline into your brain for test day. The deciduous teeth eruption timeline for a baby's first teeth is highly predictable. Knowing exactly when those lower central incisors erupt, which happens right around 6 to 10 months, is a super frequent developmental milestone tested on boards. So when parents inevitably ask you, hey, when will my baby get their first tooth? You need to have this 6 to 10 month window locked and loaded.
Next up, let's tackle a huge subjective assessment: pain. You literally cannot ask a 4-year-old to rate their pain on a numeric scale of 1 to 10. Cognitively, they just aren't there yet. When you're assessing subjective data in pediatric clients, you absolutely must use age-appropriate visual tools like the FACES scale. It ranges from no hurt with a smiling blue face all the way to hurts worst with a crying red face. It's brilliant because the child can simply point to how they feel, and it bridges that communication gap perfectly.
Okay, so once you've assessed that pain, what do you do first? The NCLEX loves to see if you're going to immediately reach for medication or if you're going to try nursing interventions first. Pro tip: before jumping to pharmacological options, always consider non-pharmacological interventions. Tools like a buzzy vibrating device, which actively confuses the pain nerves, or even just simple pacifiers and swaddle blankets are incredibly effective. Trying these first provides atraumatic relief and proves you're prioritizing holistic, safe care.
But look, there are times when you absolutely do need to administer pain control or medication via an IM injection. And that brings us to the vastus lateralis muscle on an infant's thigh. Because infants haven't developed their gluteal muscles from walking yet, the vastus lateralis is the absolute safest, most highly tested IM injection site for them. It's got a large muscle mass, and it perfectly avoids major nerves and blood vessels. Remember this site for sure. It will save you on your exams.
Let's take a step back and see how this all builds into a totally cohesive, safe pediatric assessment flow. Step 1, always start by building rapport and using therapeutic communication with both the child and the parent before you even lay a hand on the patient. Step 2, implement those non-pharmacological comfort measures. Step 3, gather your age-appropriate vitals using the correct equipment. And finally, Step 4, proceed with safe medication administration if it's needed. This step-by-step logic is exactly how you should approach every clinical scenario question.
All right, pop quiz time. Let's put everything we've talked about to the test. You have an incredibly anxious toddler, an 18-month-old, who desperately needs a prescribed intramuscular medication. Based on everything we've just covered, what is your very first priority action to ensure safety and atraumatic care? Take just a second to think about it.
If you said get the parents involved, you absolutely nailed it. The priority action is to enlist the parents for comfort positioning, maybe using that tummy-to-tummy sit we talked about, and then target the vastus lateralis for the injection. By doing this, you are flawlessly combining clinical safety with therapeutic communication. You minimize the trauma while still getting the job done.
Okay, let's lock this whole shebang in with a rapid-fire recap of the top 5 non-negotiable pediatric priorities you have to know. Number 1. The posterior fontanelle closes at 2 months. The anterior takes 12 to 24. Number 2, remember that vital sign chunking. Heart rate and respiratory rate go down with age, but blood pressure steadily goes up. Number 3, always prioritize atraumatic care and get those parents involved. Number 4, use age-appropriate pain tools, like the FACES scale. And number 5, the vastus lateralis is your go-to safe site for infant IM injections.
You are now officially armed with the high-yield facts to conquer pediatric health assessments. But I want to leave you with one final, kind of provocative thought to chew on for next time. Clinical skills and textbook milestones are crucial, obviously. But if family-centered care is our ultimate standard, how do we actually adapt to these perfect atraumatic interventions when we're dealing with, say, authoritarian parenting styles? Or when complex social determinants of health, like poor access to care, completely challenge our baseline? Think about that as you continue your clinical journey. Thanks so much for joining me on this explainer, and I'll catch you in the next one.